A very good day, my dear postgraduate students. Welcome to SNP, Short Notes in Pathology. The topic for the day is on the screen, mastocytosis. And there are many allied topics such as mast cell in health and disease, which have already been covered. Being a short note, let us see how we can approach this. Look at the panel of subheadings over here. Each one is worth its weight in gold. I would like you people to kindly be slow and deliberate in going through these headings. For example, what are the diagnostic tests, diagnostic criteria? How do you classify? What are the diseases associated with? What are the special states? So on and so forth. Think of the subheadings. The subheadings will take us to the answer. Look at this one. Obviously, I am finding multiple purpuric spots over the skin. Being a clinical condition, this has already been termed as urticaria pigmentosa or dermatographic urticaria, wherein there is probably a geography like map. Darius sign is one, somewhat similar to the Lewis's triple response. The patient can otherwise be presenting with fatigue, laryngitis, or otitis, upper respiratory manifestations. Anaphylaxis, we are all familiar with the type 1 hypersensitivity. Hypotension, ocular discomfort, peptic ulcer and diarrhea, malabsorption, osteoporosis. And having had all this, obviously there will be a depression impact. The mast cell diseases. So this terminology has come into vogue. I would like you people to kindly keep it in mind. The mast cell diseases are a rare group of disorders that affect the children as well as the adults. Here, though we call it as mastocytosis, which means an increase in cells, there is a functionally defective mast cell group or mastocytes. So look at this one. It is a electron microscopic picture that we see, wherein there are a lot of these secretory globules which are present, and they have got the haven of mediators. CD4 plus cells are the precursors of these. The mast cell is considered a jack of all trades, and it is mainly an immune cell. A variety of physiological and pathological processes are within it. These three things with asterisk, I would like you people to kindly by heart throughout. Activation by the feeding receptor binding agonists, physical activators, and cell-to-cell contact. These three things shall and will be the concept of our class. Fundamentally, there are two types of this mastocytosis. One is cutaneous, the other is systemic. Cutaneous, again, an asterisk mark. Wherever I have put the asterisk, it is your duty to by heart it. It can be maculopapular, papular urticaria pigmentosa. So that is what is denoted over here. Maculopapular urticaria pigmentosa. Cutaneous mastocytosis. Telangiectasia macularis, eruptive persistence, and TIMP. This is the abbreviated form. Children have got a greater incidence than the adults. Generalized eruption of macules are seen in adults, whereas it is diffuse, and almost the entire skin can be involved in children. Now look at this picture over here. I am finding a basket over pattern of keratin, which is quite normal. The epidermis, probably it is a little thinned out, but then in the dermis, I am finding an aggregate of cells. These cells do not fit into lymphocytes. They are not plasma cells, but then they are slightly elongated, ovoid, and Classically, they are the mast cells. The H&E stain alone will not be adequate to demonstrate them. Therefore, special stains are required and we shall see them. There can be associated disorders with mast cells. CNS disorders, whoever thought it will be there. Neuroinflammation and then BBB, disruption, multiple sclerosis, Parkinson's disease, stroke, autism, migraine. My God, what a plethora of disorders. Peripherally, bronchial asthma, we are all very familiar. And there can be any inflammation, infection, reaction, which is an allergy. Psoriasis again, atopic dermatitis, systemic mastocytosis that we shall be seeing, cancer and metastasis, itching, pain, urticaria it comes under, obesity and ulcers. There can also be conjunctivitis, rhinitis, periodontitis. And peripheral disorder that can be cardiac abnormalities, or there can be a pancreatitis, inflammatory bowel disease, interstitial cystitis and endometriosis, arthritis, of course. So look at the wide range. Therefore, it is not an easy task to just call the mast cell in health and disease. This is a very important slide. I'm finding that the masts or the mastocytes are there. They are having a K80 mutation which gets activated. After this activation, there can be functional and there can be also a proliferative. In this one, there is a proliferation of the mast cells, increased number of cells, more severe symptoms, and then the manifestations. In another one, it becomes hyperactive. There are some triggering factors. There is a mast cell activation that happens, leading to local as well as systemic symptoms and anaphylaxis. So the connective tissue, skin, stomach, etc. can be involved. It is usually a defense against bacteria and parasites. Chemical alarm is the histamine. We all know what happens with vasodilation. The cell surface c-kit, that is what I had mentioned over here. It has got a CD117 receptor from the stem cell factor for the proliferation of the mast cells. And any form of mutation in these can lead to a defective mast cell or mastocytosis. This is again an important diagram. I will not be going into too much of the details of it. Only thing we should be knowing that there can be some amount of promoters, some amount of inhibitors. So that is being made use of therapeutic target in pharmacology. So there can be activators, and then these are the things. C5a, we people know. FC receptors. Always when there are a panel of such mediators, I would advise you people to kindly go to something that you are familiar with. C3a, C5b, C3, 5b to 9. These are all certain important complements that we already know. And this will be used in dilatation, etc. FC receptors, again in phagocytosis. See what is happening over here. There is an FC receptor. You find that an antibody is already attached. And then for a second time, you find there is a re-exposure to the same antigen. This is called a cross-linking across the antibodies. As a result of which, there is a stimulus or a contraction. And then there can be the activation of the actin and the myosin. There can be a degranulation. And you get various substances, including histamine or the interleukins. And therapeutically, you find that antigens to these are being given. So I would like you to kindly by heart this box alone. It is activated via toll-like receptors, complement anaphylatoxin and FC receptor. Neuropeptides, interleukins, tryptase and kinase, we people should remember. These are important in promoting the activity of the mast cell. And tumor necrosis factor and histamine. Tryptase and kinase shall be the key in this picture. Look at this again. There can be mast cell activators. Almost the same picture as over here. So IgE is important in type 1 hypersensitivity. Look at the various complements that we had already mentioned. cytokines and the chemokines. So there is an attachment, there is a cross attachment. Other factors such as the physical factors or a cell-to-cell contact. Here probably some other cell comes in contact with the receptor, as a result of which you find that there can be the activation such as the degranulation. Mast cell molecules, preformed mediators are there which are getting released, and newly synthesized mediators such as the prostaglandins. So the mast cells are activated by 1. Receptor binding agonist, 2 is the physical activators, and 3 is the cell-to-cell contact. This box we shall and will remember. So this is yet again the same thing. It is quite simple. So you people must draw this. And remember tryptase and kinase. This is a H&E slide from the bone marrow. What are we seeing over here? There are some cells with elongated, almost cigar-shaped nuclei, blunt ends. They are diffuse, or sometimes they can be cohesive or multifocal. They are all the atypical mast cells that are being seen. Eosinophils, of course, go hand in hand with the mast cells because of the reactions. The cell as such is quite spindle-shaped. I hope you people can appreciate the outline of it. And the atypical features can include immature chromatin or multinucleation. Thanks to this particular reference, a wonderful work that has been done. This is a very important slide, almost something to the maturation of the leukocytes. So here I'm finding the mature mast cells, A to D. These are all the mature mast cells. Slightly they may get elongated, by then they have got certain kind of granules that we shall be seeing. From E to I, they will progressively become some kind of immature. Obviously, I'm finding a change in this one when compared to this. And there are, of course, the granules over here. And finally, you can get ungranulated blast also in K. So this is important. So there is a kind of transformation from the mature cell, and it can be a kind of a primitive cell that ultimately develops, that can be what is called as a mast cell leukemia. Thanks to this wonderful picture from this reference. Evaluation. Always a diagnosis can be clinical, it can be pathological, or it can be based on laboratory diagnosis. So you find that there has to be a complete medical history, what are the symptoms and so on, and what is somewhat blocking the symptoms. And there can be an advanced evaluation. You can get the pictures such as a CT, for example, a laryngeal edema, gastroendoscopy for a peptic ulcer, biopsies later on, and the other lymph nodes which are being elevated, liver function tests, so on. And the workup that is to follow will be the laboratory evaluation. So there is a CBC, renal, biopsies, etc. Serum tryptase, again, please do remember this, calcium, etc. Bone marrow, you will be able to have this one. A bone marrow biopsy is always essential for demonstration of the K80 mutations. Bone densitometry is recommended because of systemic mastocytosis. There are certain diagnostic criteria. Just as the major and the minor criteria you have elsewhere, here also there are some criteria which we shall be seeing. So there is a major criteria. Presence of clusters of abnormal mast cells greater than 15% of the mast cells in the bone marrow or in the extracutaneous tissue. Probably you count the number of fields and then 15% of it is supposed to be indicative of a major criteria. Otherwise, minor criteria such as elevated tryptase levels, abnormal CD25 expression, or KIT-D mutation, and the presence of greater than 25% of atypical cells. Apart from this, there can be systemic mastocytosis. So ultimately, you find that one major and one minor or three minor itself can be diagnostic of mastocytosis. Please do remember the criteria. It is going to fetch us marks. And there can be the other findings. Bone marrow, over 30%. 30% always do remember. Be it a leukemia or a myeloma, this 30% has got some meaning. Abnormally high tryptases, hepatomegaly, splenomegaly, and lymphadenopathy. And there can be the other cytopenia, splenomegaly, pathological fractures thanks to osteoporosis, malabsorption, and peptic ulcers. The mast cell leukemias. This is a weird term, and I'm finding mast cell is nothing but the tissue counterpart of the basophil. And in this, I'm finding round cells which are having coarse granules, which are almost obscuring the details of the nucleus. Classical of a basophil. It appears almost like that. Only thing they are immature. And there can be metachromatic granules. What is this metachromatic? Whenever you do a staining, methyl violet, crystal violet, etc., you find that the substance that you tend to demonstrate takes up a different color, whereas the background takes the color of the stain. That is called as metachromatic. I shall be dealing with that under the H&E stains. Positive for alpha-naphthyl chloroacetate esterase, negative for peroxidase. So obviously it is not a myelocytic series that I'm seeing. Positive for CD13, 33, 68, and 117. Negative for 14 and 15. So that will be diagnostic of mast cell leukemia. This again is a WHO of systemic mastocytosis. This is another table that we will have to remember. So it can be indolent, it can be smoldering, it can be aggressive, it can be systemic mastocytosis along with hematological neoplasm. That can be a mast cell leukemia. Again, you find that there can be a subtype of this. AHN is mastocytosis with systemic mastocytosis and is hematological manifestation. So there can be an acute myeloid leukemia, dysplastic syndrome, or myelodysplastic disorder, CML, hypereosinophilic syndrome. These are certain things which you'll have to remember. Change this to SM, systemic mastocytosis with AHM. There is also a differential diagnosis. Always these clinical syndromes need not be mastocytosis. It is quite weird and vast. So there can be a carcinoid syndrome wherein there can be vasodilation, there can be flushing, etc. Vipoma, Zollinger-Ellison syndrome, multiple ulcers, peptic ulcer, one of the causes for it. Acute urticaria and inflammatory bowel disease, irritable bowel syndrome, malabsorption, myeloproliferative disease. This can be a broad band of differential diagnosis. Have it in mind, write it in your exam. And for the diagnosis, 4 things are mandatory. One is biopsy of the skin, serum tryptase that we have already mentioned. PCR is essential for demonstration of the kit. D816V. Criteria for mastocytosis. We have seen the 1 major and 1 minor or 3 minor criteria. So that will be essential for the diagnosis. The prognosis in a case of mastocytosis depends on multiple factors such as a low platelet count, low serum albumin, low hemoglobin, elevated lactate dehydrogenase, older age, and high alkaline phosphatase, hepatosplenomegaly, ascites, excessive bone marrow blasts. Obviously, this is the acute leukemia transformation. There is a weight loss, and there is also this kind of mutation. So this will be essential to judge, to develop the prognostic index for the patient. The complications can be, again, it goes hand in hand. There can be a monoclonal gammopathy, there can be a hairy cell leukemia, non-Hodgkin's lymphoma, polycythemia vera, primary thrombocythemia, anemia, hepatosplenomegaly, hypereosinophilic syndrome, Castleman's disease, coagulopathy, and recurrent anaphylaxis. I had mentioned about the special stain. In this one, you find that there is the toluidine blue. In this particular first slide, wherein I'm doing the staining, and then there is a JMSA. JMSA is almost like your Leishman stain, a Romanowski stain, which takes up a blue color, whereas this is somewhat sky blue, the toluidine blue. So this can be done along with the esterases. Immunohistochemistry, the C-kit, is essential for the diagnosis, particularly in case of biopsies. Thanks to Michael Hagedstrom, Wikipedia. These are the references in a case of mast cells. And Look at this particular one. The mast cell, it gives us the correct direction. I hope you people have enjoyed the class and we shall be seeing what is essential. So any particular one, think of the subheadings. The subheadings will take us to the answer, whether it is a SNP or an essay. Think of the mast cell, it will give you a sense of direction. Thank you.